Good afternoon, everyone. We'd like to welcome you to Care New England Grand Rounds. It's a virtual program which was started a few months ago in order to allow people to, or facilitate people to learn from one another, to share their challenges at work, and also at this point in time when people aren't gathering together very often, to get to know one another. Today, we're very fortunate to have as our speaker, Dr. Laura Forman. Dr. Forman is a graduate of UVM College of Medicine and has an extensive background in refugee and international health, having worked in the Balkans, Central America, and Africa. She did her training at Bay State Medical Center and was chief of emergency medicine at Memorial Hospital before coming to Kent Hospital, where she's the current chief of emergency medicine, as well as a clinical instructor in emergency medicine at the University of New England School of Medicine. At this point, I'd like to ask Dr. Forman to join us, and we will begin. And then we'll have time for questions and answers at the end. So we appreciate your joining us, and welcome, Dr. Forman.
Thank you so much. It's really an honor to be here today in this virtual space, as strange as it is with everybody. Can everyone see did I manage the screen sharing okay? Can you guys see the screen all right?
Yes.
Okay, excellent. Sorry, this is my first Zoom Grand Rounds. It's my first Grand Round, so just want to make sure I'm getting everything right. So I want to encourage all of you to participate in the next hour. Please feel free to unmute yourselves and jump in at any point to ask questions or add your share stories to talk to anything that I'm talking about here. So I will start my talk with this, just briefly going over the objectives. And then I wanted to start with talking about how when I began my career in emergency medicine, I very naively underestimated the connection between my work in the emergency department and public health. So emergency medicine, by its very nature, is the most reactive of specialties. We are the repair people after the fall. We are not the designers and the preventative planners. And as a specialties, we're also an extremely individualized one, by which I mean that we tend toward a really myopic view on the person in front of us. The exigent nature of what we do in the emergency department means that we inherently focus on the individual and not the work of a broader system that culminated in the patient arriving in the emergency department. And this is perhaps the very antithesis of preventative and public health in many ways. But working in emergency departments in one capacity or another, over the past 25 years, I've slowly noticed over the thousands of days and the tens of thousands of patients, a pattern emerging, a pattern of who comes through the doors, of why and what led them to the emergency department, and what will keep them away from the emergency department, of what keeps them returning time and again to our trauma bays, to our critical care rooms, to our detox beds. And this pattern that leads to people's lives intersecting with mine in the emergency department time and again is driven by what we call the social determinants of health. So the social determinants of health are those features of the social environment that influence our individual behavior, our disease, and our health status. They are the conditions into which we're born and in which we live, work, love, and play. They are the factors outside of our control that dictate many of our choices. The social determinants of health dictate what we have access to. They dictate what we're exposed to, whether that's healthy food and green spaces and good schools, or air pollution and gun violence. And these determinants not only create behaviors, but they make some of the individual choices that we take have risk or not. When we look at an individual's health, when we look at how an individual maintains health, how they lose it, it's the social factors that dictate what choices they actually have to choose from in regards to health and wellness. So my personal introduction, or my medical introduction to the social determinants of health, came when I was working in an inner city emergency department in Oakland, California. I was taking care of a 16-year-old African-American teenager who had been shot in the leg. It was a drive-by shooting. The bullet went straight through his calf, and he was otherwise totally unharmed. So he got x-rays and vascular studies, and I sutured up his wound. And as I was ready to discharge him home, I was bandaging up his lower leg, and he called his mom for a ride. And his end of the conversation that I could hear as I was bandaging him went something like this: "Hi, Mom. Yeah, no, I'm in the ER. No, I just got shot again. No, I'm fine. No surgery this time. Can you come pick me up? Oh, okay. Well, yeah, no, I can wait. I'll see you out front in a couple hours when you get here. So I could neither in that moment imagine being 16 on my own in the ER after yet another gunshot wound, or imagine being the mother on the other end of that phone call. And I thought about my own mother and how she would react were I to call her from a ED trauma bay with that news. And I realized that I didn't have words in that moment for the chasm that existed between our experiences and between the experiences of our mothers. I realized how different the forces were that brought me to that trauma bay in a white coat with a stethoscope and brought him there with a bullet wound. And these forces are the social determinants of health. So I'm going to talk today about what I see as the most powerful of these social determinants of health, which is racism. And I want to preface this talk by saying that I'm going to share with you just what I've learned so far, but this is by no means a comprehensive talk on all facets of racism as it relates to healthcare. The field is vast. The health disparities are broad. They are staggeringly massive. And I'm not an epidemiologist or a social scientist. I'm just an ER doctor. But I've been struck by how profoundly racism impacts all of us, whether we see it or not. And I think it's really necessary to talk about it. I'm not sure how to talk about this, to be fully honest. I've been wrestling with it. This is an incredibly difficult and painful issue with roots deep in the history of our country. I don't have all of the answers. And as a physician, not having all the answers makes me want to hide behind the safety of anonymous data and statistical discussions. But I don't think that those alone are going to solve this. I think that as intimidating as this feels to me at times, I want to share with you today my small contribution to the discussion on the issues of racism in healthcare, because the more I think about it, the more I see it. And the more I see it, the more I see how harmful it is, how much it affects all of us. I would guess that some of you on this call have been talking about these things and having these discussions for quite some time. And I would guess that some of you have not talked about this yet. But I want to urge all of us at Care New England to come together to talk about this openly, find ways to do better by our patients in our community, because racism profoundly impacts health and it profoundly impacts our ability to take care of our patients. Before going any further, I want to lay out some basic definitions and differentiate race itself, which is a social construction with no real biological basis, right? There's data that shows that there's actually more genetic variation within racial groups than between them, from racism, which is the social system that enforces inequity on the basis of racial categories. So race itself is not what actually impacts individual health or public health. So being, for example, Black in America doesn't tell us much about one's health risks, but being black rather doesn't tell us much about one's risks, because that's just a racial category. But being Black in America, which is a racially stratified society, does, because being Black in America has negative implications for educational and professional trajectories, for socioeconomic status, and therefore has negative implications for access to healthcare and the resources that promote optimal health. So this in turn exacerbates health risks on the basis of racism, but not on the basis of race itself. Please feel free to jump in at any point if this isn't making sense or you have other thoughts. So racism itself is a system of power. It's not an individual character flaw. It's not a personal moral failing. Individuals can engage in racist acts, but racism itself is the system that assigns value on the basis of race and then hands out opportunities accordingly. And this system is embodied in a set of policies that are both formal and informal, policies that are both spoken and unspoken, and these policies are put into place in order to maintain the disenfranchisement of a group based on race. So in talking about health and healthcare, this is a really important distinction, racism from race. Race in a vacuum doesn't tell us much about a person's life and health, but race in a context of a racist society does. Racism permeates all domains of our life, social, political, legal, and medical, even if we don't readily see its power and we don't readily see its pervasiveness. Because the effect of racism is to disadvantage some individuals and communities, there's therefore a reciprocal effect, which is to advantage others on the basis of race. So we're all impacted by racism, just in different ways, depending on our race. Some among us have privilege based on race or based on our perceived race, and some among us have disadvantage. So when we look at our society through this lens, we can start to see the ways in which racism functions as a social determinant of health. One of the best frameworks that I've heard from this comes from Dr. Camara Jones, who's a physician and an epidemiologist. She's currently a Radcliffe Fellow at Harvard, and she's focused her career on looking at the impacts of racism in health and well-being. She uses an allegory of people on a cliff to talk about racism and the social determinants of health in the setting of our current healthcare system. So she has us imagine a cliff and imagine a group of people up at the top of the cliff, and the people keep falling off of the cliff onto the valley floor below. And she says, when you look at this scenario as a healthcare provider, you start thinking about like, oh, what can I do to help these people who are falling? The first thing that some of us might think about is, well, what if we got an ambulance to take the people away who've fallen onto the ground, and we could bring them to healthcare after they've gotten injured? So you think about it a little bit further and you might start thinking, well, what if instead of just picking them up once they've fallen, we put up a net so that when they fell off the cliff, we could catch them in the net and then they wouldn't get hurt at all. The thing with nets is that they have holes and people can fall out of them. So maybe what if we put up a fence at the top of the cliff so they wouldn't even fall down off of it? She says, if you start thinking about this further, what we might come up with as the best solution is in fact not a net or a fence or an ambulance, but to push people back from the edge of the cliff so that they didn't even come close to the edge of it. So when you look at this allegory as a healthcare provider, you can start to label the parts of it with the corresponding aspects of the healthcare system. Bear with me for a minute. I know this might not make sense, but it helps to understand it a little bit. So the ambulance down at the bottom of the cliff is acute medical care, right? This is tertiary prevention. This is where I work along with many of you on this call. The net is our safety net programs and our secondary prevention, and then the fence is primary prevention, and that's where many others of you on this call work, is primary and secondary prevention. And then moving people back from the edge of the cliff, that's public health. That's addressing the social determinants of health that I was talking about. To make this more concrete, we can look at a specific example that we all deal with on a regular basis and look at diabetes in the context of this allegory. So the ambulance in this case is tertiary and emergency care of people with diabetes. So it's treating DKA, it's doing amputations, it's taking care of people with heart disease and strokes due to diabetes. The net is primary care. It's giving people insulin and oral medications for diabetes. It's monitoring their glycemic control. The fence itself is giving diabetics education and information about healthy eating. And then we move people back from the cliff's edge by ensuring that everyone has access to healthy food, by eliminating food deserts in our poorer communities, and by starting healthy eating habits in childhood through education, regardless of socioeconomic status and race. So I think about this working in the emergency department now, and I think about how my diabetic patients at Kent now on the whole come to me in very different conditions than my patients did when I worked at Memorial Hospital in Pawtucket, which is predominantly a community of color. And then they did during my residency in an inner city trauma center with a much more diverse patient population as well. There was a gentleman at Memorial Hospital who I took care of many times over the years that I was there. He was in his 40s when I took care of him. He was African-American, he was obese, he had been diagnosed with diabetes and hypertension in his 30s. By the time I met him in his 40s, he'd already been diagnosed with chronic kidney disease and coronary artery disease as well. He worked as a day laborer when he could find work and was mostly homeless in the 3 years that I knew him. He stayed mostly with different friends and sometimes family. He typically didn't take any of the nearly 1 dozen medications he was prescribed on a daily basis because he moved so frequently from place to place that it was hard for him to keep on schedule, and he wasn't usually able to refrigerate his insulin. His diet consisted of just what he could afford and what he could find locally, so because he didn't have a car, so it was mostly fast food. He had a hard time sleeping because he had PTSD from childhood, and crashing on friends' couches didn't help with his sleep hygiene. He picked up work when it came along, which meant it was really hard for him to make it to his PCP appointment. So he used to joke that we in the emergency department were his PCP, but in the emergency department, we're not very good primary care doctors. When he came in, we'd bring down his blood sugar and his blood pressure, and we'd give him a turkey sandwich, and we'd give him a few days worth of free medications. I remember this gentleman because he told really good stories and he had a great sense of humor, but not because his case was at all unusual. Memorial Hospital's emergency department and the emergency department of the inner city hospital I worked at in residency were full of patients with almost that same exact story. But in the Kent emergency department, among my primarily white patients, these kind of cases are few and far between. Even from my vantage point in the emergency department at the bottom of the cliff in the allegory, I can see how different the top of the cliff looks for different patients. For some parts of our population, the cliff is as I first described it, but for others, like for my patients at Memorial, the area leading up to the cliff was slippery and was sloped down right up to the edge, and people were pushed, crowded right up against the edge of that cliff. The fence was maybe missing entirely, and the net had fallen apart, and maybe there's an ambulance at the bottom, but it's out of gas and the tire is flat. Not everybody's cliff is the same. We all have different cliffs, and we have different choices around our health because of the systemic inequalities in our country. We have different choices around our health because our nation's history is one of segregation and unequal treatment on the basis of race. And we have different choices around our health because these historical racial disparities persist today in institutionalized racism in our communities. These racial disparities are clearly evident in the social determinants of health, in the factors that are beyond our control that impact our ability to stay healthy or not, the forces in our environment that influence the choices we have, our behaviors, the forces that bring me to the trauma bay in a white coat with a stethoscope and others with a bullet wound. We can all understand, sadly, that the health outcomes, so much of health outcomes are dictated by what happens before someone even comes to us, right? Health is in large part influenced not by what happens in the medical profession, but what happens in the community, what happens in schools and neighborhoods and streets, not what happens in hospitals and doctors' offices. And here's a place where racism is really readily apparent. So living in a racially stratified society like ours means that these factors, these social determinants of health, these forces, differ systematically along racial lines. There's a tremendous amount of research now that I'm going to share a little bit of with you about health disparities among different racial groups within our country. For the scope of the limiting, for the sake of limiting my scope of talk today, I'm going to primarily focus on the data that reflects health disparities for Black and white Americans, but this is in no way intended to downplay the impact of racism on the health of other communities and people of color in our country, because in our country, the disparities are seen among many racial and ethnic groups. So racial stratification is painfully visible these days in the police violence that kills Black Americans at more than 3 times the rate of white Americans, but it occurs in less visible ways every day. For generations, communities of color in our country have faced vast disparities in job opportunities and income and inherited family wealth. They're less likely to have housing security and access to high quality schools, healthy food, green spaces. Mass incarceration is another example of systemic racism having a significant impact on public health. So current estimates are that Black men are incarcerated at nearly 6 times the rate of white men in our country. And this mass incarceration is largely a result of racism in our institutional policies and our institutional judicial and policing policies. The consequences, though, of this extend far beyond the prison sentence. So a criminal record disqualifies individuals for a lot of social programs, for some housing and unemployment. And all this is not just detrimental for the health of the individual, but for families and then communities of color as well. Black Americans are more likely than white Americans to live in communities with a high degree of air pollution and environmental exposures. This study shows that due to residential segregation, Black Americans are 75% more likely than white Americans to live near a polluting facility like a factory or a refinery, which in part explains why even before the pandemic, Black children had a 500% higher death rate from asthma than white children. I worked overnights in the Memorial Emergency Department for years, and like clockwork, we would get nightly visits in that emergency department by kids with asthma, kids who lived in spaces without access to electricity, so they couldn't use their nebulizers at home and didn't have air conditioning in the summer, kids whose medication had been lost in the transition from one homeless shelter to another, kids whose parents couldn't afford their albuterol or steroids. I used to have large sections of the $4 prescription list at Target and Walmart memorized, as well as routinely calling CVS or Walgreens in Pawtucket and Central Falls to give them my credit card number along with the patient's prescription so that the parents could afford to pick up their kids' asthma medications. I can't remember the last time I needed to do that with my Kent patients. And I've all but forgotten what was on the $4 list. But I still think about those kids, and I think about the parents who came in with them, both terrified and ashamed. In addition to the consequences of structural racism, it's well documented in studies from the US and abroad that racism itself is hard on a person's health. Chronic stress caused by discrimination can trigger a cascade of adverse health outcomes, from high blood pressure and heart disease to a weakened immune system and accelerating aging. Profound chronic stress impacts us in insidious ways, as we well know. And I realize as a clinician that this impact on my patients might be invisible on a day-to-day basis, but it's powerful nonetheless. So these social inequalities become embodied as health disparities, and the disparities lead to vast differences in baseline health status before someone even comes into contact with the healthcare system. The demographics show another interesting layer, which is that racial and ethnic health disparities are seen at every level of income, meaning that money doesn't prevent this, nor does education. When I was a resident, one of my fellow residents died of a postoperative PE after a routine orthopedic surgery. And I remember at the time thinking that it was a fluke, a young, seemingly healthy person dying. But in retrospect, I wonder if the outcome would have been different if she had been white instead of Black, because I now know that statistically her chances of dying would have been smaller. Across the country, Black Americans suffer from higher rates than white Americans of diabetes, asthma, and stroke when compared with others. They're more likely to get obese. They're more likely to get insufficient sleep, which, as we well know, can contribute to a myriad of healthcare issues as well. CDC data reflects vast disparities in cardiovascular and stroke health outcomes based on race. So African Americans in the age group of 18 to 49 are much more likely to die from heart disease and stroke when compared with white Americans. They're much more likely to have hypertension, and nearly half of adult African Americans have some form of cardiovascular disease. CDC data also shows stark racial differences in women's health. So African-American women are more likely to die from cervical cancer. They are 243% more likely to die from pregnancy or childbirth related causes than a white woman. And then preterm birth and infant mortality are also significantly higher in African-American women than in whites. it would follow that overall life expectancy is significantly impacted by racism in this country as well. So in the US, there is an overall shorter life expectancy for Blacks when compared to white, with a difference of approximately 5 years. When you stratify the data geographically, then the numbers actually vary significantly. So in certain wards of New Orleans, for example, the average life expectancy for a Black newborn is 25 years shorter than it is for a white newborn. Another example is a community in Kansas City, Missouri, where two neighborhoods have recently drawn the attention of public health researchers. They're only 3 miles apart. So one of them is called Blue Hills, and Blue Hills has an average life expectancy of 69 years. Blue Hills is 86% African American. 3 miles away is Armour Hills, which has an average life expectancy of 83 years. 84% of Armour Hills residents are white. Another way to look at the national numbers for our country is to understand that the best ever African-American age-adjusted mortality and life expectancy to date in this country was in 2014. That year, the average life expectancy for African-Americans was 75.3 years. White Americans had that same life expectancy back in 1989, but it's steadily risen since that time. So white mortality progress is 20 to 30 years ahead of that for Blacks in this country. There was a recent paper from a demographer at the Minnesota Population Center to put these differences in mortality progress in the context of the COVID-19 pandemic. So the researchers wanted to look at the impact that racial equality has on life expectancy for Black Americans and see what the equivalent impact would be for white Americans if COVID-19 were as deadly as racism was. So they found that for COVID-19 to impact life expectancy for white Americans to the extent that racial inequality does for Black Americans, the current COVID-19 mortality rates for white Americans would need to increase by a factor of nearly 6 to have the similar impact on life expectancy. So for COVID-19 to raise mortality rates for white Americans as much as racial inequality does for Black Americans, they found that we would need an excess 700,000 deaths for white deaths for COVID-19 this year to make those numbers equal. So these differences aren't due to race itself. There's no underlying genetic predisposition to these diseases and these conditions. And numbers of this magnitude with this scope are not simply reflective of an individual's choices. In our society, and certainly within my field, we often focus so intently on the individual that we don't look at the conditions that constrain their choices. We talk about poor compliance, we talk about bad choices, we talk about people not adhering to care. And when we look at these individual choices, we often ignore the broader context in which this occurs, and we don't see the choices that they actually have to choose from. You know, we ask, why are they eating so much fried food and soda instead of eating vegetables and drinking milk? Why aren't they wearing their seatbelt? Why aren't they taking medications? Why didn't my patient go to their checkup or their health screening? What we don't see in these cases, when we look at the individual, is the food desert in which they live. We don't see the lack of healthy food options. We don't see the financial strain and the reality that fried food and soda are cheap and plentiful and heavily marketed to our communities of color. We're not seeing the lack of transportation, the increased risk of violence people live with, and the lack of economic opportunities in disadvantaged communities. All of these factors undoubtedly undermine health and well-being for people. One only has to look as far as the patients at Memorial and then the patients at Kent, or drive through Central Falls and then through East Greenwich to see the different choices people have that either limit or encourage good health. And these social determinants have impacts far beyond those of an individual's choices. The next place that we can see health disparities and the impact of racism is in access to healthcare, particularly in primary care and preventative services. So my diabetic patient at Memorial's emergency department was only one of many who referred to the ER as his PCP's office. And while we're good at many things in the emergency department, preventative services and primary care are not among them. We're a poor substitute, and yet for many people in communities of color, we are their only source of primary care. Research has shown that differences in access to resources and adequate care are one of the areas in which racism has a very clear correlation to poor health outcomes for people of color. Limitations in access for individuals in community of color is multifactorial. Lack of insurance is certainly one of the major access issues. People of color are more likely to lack adequate health insurance when compared with the white population. And this leads to, as we would imagine, increased delays in seeking healthcare and a decreased ability to access necessary preventative care as well as access treatment and medications. Since the Affordable Care Act core coverage provision came into effect in 2014, uninsured rates have fallen across all racial and ethnic groups, but the rates are still significantly different for people of color. This disparity could be significantly reduced if we could expand Medicaid under the Affordable Care Act, but so far 12 states have refused to do this, including some of the states that have the largest populations of Black Americans. So Black Americans remain significantly more likely to be uninsured than whites, and Hispanics remain significantly more likely to be uninsured as well. even once insured, there are discrepancies in the plans themselves, as we all know. So the numbers don't tell the stories of the people who have limited insurance plans that restrict their access to services and restrict the number of providers that they can use. Being the safety net in the emergency department means that we see a lot of the patients who can't access the right care in the right place. And we hear a lot of the stories about the barriers that people encounter. My 49-year-old patient who couldn't get a mammogram despite a very strong family history of aggressive early breast cancer because she saw a different provider every time she went to the clinic and hadn't been able to get a referral. Through my 35-year-old who I diagnosed with metastatic cancer, I learned that insurance coverage through Medicaid isn't available to what's called a qualified non-citizen immigrant until they've been a resident in the US for more than 5 years. Through a 19-year-old woman who had been trafficked to the US, I learned that the group not eligible for Medicaid not only includes refugees and asylum, but immigrant victims of trafficking and their children. One of my emergency departments, a 41-year-old diabetic who's had one BKA and is likely to have a second one this year, comes to the emergency department for his medications and his checkups because EMS will bring him there, but an ambulance won't bring you to a PCP's or a specialist's office. He doesn't drive and he lives far off of a bus route. Other patients end up in the emergency department because of language barriers or lack of providers in their immediate geographical area. All of them feel that they have no better option but to come to the wrong place for their care because they can't access better. And these discrepancies in access remain a major area of racialized health inequity in our country. The third place that we see racialized difference, and probably the hardest one for us in the medical community to face, are the differences in the type and the quality of the medical care that people receive along racial and ethnic lines. Let me say that again. The differences in the type and the quality of medical care that people receive along racial and ethnic lines, meaning the reality that people are treated differently by us depending on their race and ethnicity. There's a legacy of racism and discrimination that persists in modern medicine, and it's seen across many of our specialties. In my own field of emergency medicine, there's been extensive research published on the disparities in the treatment of pain by physician along racial lines. Several studies have documented significant racial disparities in emergency pain management. We know that Black people, for example, with long bone fractures get fewer pain medications than white people with the same exact fractures, in addition to lower potency narcotics being prescribed at the time of discharge to people of color when compared to white people. Research has shown that Black Americans are less likely to get invasive cardiology procedures. Racial disparities have been documented in the rates of AICD implementation after cardiac arrest, cardiac resynchronization with defibrillation in patients with advanced heart failure, PCI in both acute and chronic coronary artery disease, and stress testing in low and intermediate risk chest pain patients. Black Americans with lower extremity ischemia are 1.9 times more likely to have an amputation than white patients. White patients are much more likely to undergo limb-preserving mechanical revascularization procedures. This is a study of almost 700,000 patients that was conducted at urban hospitals, and the study's findings showed that the severity of the disease was not actually the explanation for the unequal treatment as is often suggested. We know that Black Americans are less likely to receive thrombolytics for stroke when compared to white Americans. And Black Americans are significantly less likely to survive cardiac arrest, even when it happens in the hospital, with lower rates of survival both during the immediate resuscitation and the post-resuscitation period. Volumes of research clearly show that Black Americans do worse in many aspects of the care we deliver to patients. And it's evidence in the data that these differences in medical care are not entirely explained by other factors, meaning there's something else there in our care, the care that we're giving itself. Very few of us would probably be readily able to name an overtly racist colleague, but we have to consider both personal and systemic racism and unconscious bias as a contributing factor in the racial disparities and ethnic disparities in medical care. A true understanding of why these disparities occurs can't be obtained without us accepting that we in the medical community are complicit in the systemic medical racism and in the disparities, that even when we try to do everything right, we can still be part of harmful outcomes for our patients. Our field has a long history of racism, and the history has not only harmed patients, but it continues to sow mistrust in communities of color about physicians and medical field itself. Perhaps the most well-known embodiment of this history is the Tuskegee experiment, the last survivor of which, Ernest Hendon, died in 2004. For those of you who are unfamiliar with the study, it was undertaken in the US by the US Public Health Service from 1932 to 1972, within many of our lifetimes. African-American men in the study were deliberately denied effective treatment for syphilis, and they were in order to observe the natural history of the untreated disease. The men were only told that they were receiving free healthcare from the US government and not that their syphilis was going untreated. It's been said that the study itself revealed far more about the pathology of racism in syphilis than racism in medicine than it does about the pathology of syphilis itself. But the US medical community's history of discriminating against and exploiting Black people far predates Tuskegee. Historically, medicine has used Black people's bodies without consent for its advancement, whether through grave robbing for surgical and anatomical experimentation, or through the use of slaves and free Black people during the antebellum period as subjects for medical experimentation. Our long legacy of exploiting and discriminating against Black Americans remains embedded in the community's collective consciousness and remains a source of distrust of physicians and research today. So all of these factors, the quality of medical care itself, differential access to medical care, and the differences in the social determinants of health, the choices that people have, they're all profoundly impacted by race and ethnicity. I don't think that this is by coincidence. Structural racism is woven into the very fabric of our culture, and it's a pervasive force among every American institution, and healthcare simply isn't immune to that. As Evelyn Hammonds, who's a historian of science at Harvard University, stated, there's never been any period in American history where the health of Blacks was equal to that of whites. Disparity is built into the system. The COVID-19 pandemic has made plain many of these inequities for the whole world to see. We can see this in our own state with differing rates of infection by county. I've heard it, as I'm sure many of you have, in the voices of my colleagues that I talk to who work in Queens, in Detroit, in New Orleans, in hospitals, taking care of predominantly communities of color as opposed to those who are serving predominantly white communities. It's been a stark demonstration in this pandemic of how social determinants of health impact population. Epidemics and pandemics flourish among the most disadvantaged in any society. This happened with AIDS, it's happened with cholera and dengue and tuberculosis, and it's happening again with COVID-19. Pandemics and epidemics reflect the marginalization and the discrimination and the disadvantaged in our populations. CDC data on COVID-19 has shown higher rates of infection and higher rates of mortality in specific geographic areas. And when we further stratify this, we can see staggering differences in morbidity and mortality along racial and ethnic lines. So for example, rates of hospitalization and death in Louisiana are twice as high for Black patients as would be expected on the basis of demographics. All told, predominantly Black counties are seeing 3 times the rate of infection with COVID-19 and 6 times the rate of COVID-related deaths when compared to predominantly white counties. It's been hypothesized that this is due to a number of different factors: the increased exposure to COVID-19 among people of color due to their disproportionately high representation in frontline service occupations, coupled with a greater likelihood of living in urban areas with high population density. In addition, people in communities of color are less likely to have insurance to pay for COVID-19 testing and are more likely to have limited access to healthcare due to financial limitations. Social determinants obviously also have a major impact on how people fare in the pandemic as well. So there's recent data that shows that a person who lives for decades in a county with high levels of fine particulate air pollution is 8% more likely to die from COVID-19 than someone who lives in a place with just 1 unit less of that pollution. So the convergence of all these factors, the social determinants of health, which are shaped by centuries of racism in our country and leave Black Americans with a higher burden of chronic disease than white Americans, with higher rates of the diseases that we know make COVID more dangerous, combined with the increased exposure and the limitations on access to quality healthcare for communities of color in our country, all make a compelling case for why we're seeing such increased morbidity, infection and mortality rates for Black Americans in the pandemic. So what do we do about this? Or is it our job to do something about it? Why is addressing racism and its structured inequities a function of healthcare providers? So through our daily interactions with patients, we can see these large-scale social forces at play. We understand who gets sick and who gets injured, who has access to care, is linked to a host of social determinants. And yet, as Dr. Paul Farmer has pointed out, this awareness is seldom translated into formal frameworks that link social analysis to everyday clinical practice. We as clinicians focus on biology. We focus on the molecular answers to medical questions and less on the biosocial etiology of disease and healing. But the natural history of so many of these diseases we all treat include social determinants, racism, air pollution, inadequate housing, poverty. But as a medical community, how often do we actually cite these as risk factors? How often do we name this in our clinical practice, despite the fact that it limits our very effectiveness on a daily basis? I would venture that few among us in our traditional medical training were really taught how to understand such social forces, nor were we trained in how to fight them from a system perspective. We were taught to focus on our technical and clinical skills, but not as much on the systemic issues that actually bring patients to our door. These are conversations, but how many of our medical interventions, will fail if we don't actually address the social determinants of disease? These are the conversations that I think we need to start having, both amongst ourselves and amongst the general public. I believe this is a really important next step in moving forward. As health professionals, we have a societal position that gives us a voice and it gives us leverage in conversations around health, and we shouldn't let that go to waste. We can help people think about health and disease as not just a series of individual choices, but as a part of a wider system of social forces beyond the control of our patients. We can become involved in community-engaged advocacy to reshape healthcare policies and laws. I'm sure that there are many in our field who would say that advocating for systemic change is not our job and that we should stay in our lane. But if systemic racism has a greater impact on disease and illness than any conventional clinical intervention that I can make, for how long can I afford to stay quiet and ignore it? I do want to acknowledge that it's difficult often to recognize where our own privilege lies. I think it's hard to see a system of inequity if it benefits us. It's difficult for some white Americans to recognize white privilege and racism. And in fact, not recognizing it is part of the privilege itself. But those with privilege can challenge themselves to see what other people experience. And when we're looking at racism within medicine, we can look at where we fit into that, whatever the color of our skin may be. I do find it easy to talk about inequities in healthcare as a distant phenomenon, like, oh, look at what happened over there. But it's not just over there, and it's not just at other hospitals. It's not happening in some alternate universe. It's happening at our hospitals. When we look at pain medication in long bone fractures, when we look at thrombolytics and stroke, when we look at workups for chest pain, and we look at maternal mortality, we need to actively look at and talk about our own role in this, our role as individual providers and our role as a group. How are we treating these patients differently along racial lines? We have to continue to review the evidence that says that these differences in outcomes are not entirely explained by other factors. Every department can approach these evidence-based realities behind the data from the vantage point that we are, as a medical community, complicit in the creation of these disparities. And that's an uncomfortable thing to say. That's a really hard thing to swallow. I look at my own clinical practice and I wonder, where have I been complicit in racist medical practices? Have I prescribed fewer narcotics for people based on race? Have I not admitted somebody for evaluation of chest pain based on a subconscious bias? Working in a racist system, which we all do, means that unequal treatment, however, is the norm. So it means that unless we're actively working against it, we're all perpetuating the system of inequitable medical care for our patients. But we can all participate in research to better understand care disparities in our own practices and to understand the human and system factors that create them. And as we continue to answer the demands of regulatory bodies, we can be wary of unintended consequences of new policies and initiatives. We can actually create and advocate for policies that address systemic racism and protect patients from damage instead of perpetuating the current inequities. In drafting guidelines for management of pain or treatment of acute coronary syndrome, we should overtly discuss how to avoid racial disparities in care. This work to inform institutional policies needs to be done at both a departmental and a systems level. One of the things that I've heard time and again from my patients of color is how hard it is to come to a hospital or a doctor's office when no one there looks like them. And this makes sense to me. As a gay person, I sometimes feel scared about encountering homophobia in places where I want to be able to feel safe. And so I'm more comfortable with a healthcare provider who's gay. And I don't mean to equate homophobia in our society and my experiences as a gay woman who can pass as straight for the experience of being a person of color in our country. But these life experiences make me understand that sometimes if I were a person of color, I probably wouldn't feel safe coming to an emergency department when every other face in the room is white. Given the level of racism in our society, I imagine it could be really difficult for some of our patients to feel safe in this setting. We need diversity at every level of medicine. We may not be able to overcome poverty in our lifetimes or all of the inequities and fix all the inequities in schools and housing and air pollution, but we can do something about the environment in which we work. We can bring people from diverse backgrounds into our workforce and better represent our community and therefore provide better care for everybody. Mary Bassett, who was the New York City Commissioner of Health from 2014 to 2018, speaks very eloquently about how inequities are embedded in our world, often in ways that are invisible to those of us who have privilege and power. Systemic racism leads to disparities along racial lines. Medicine is not immune to racism. Medicine is not colorblind. And the effects are devastating. They're devastating to individuals, and they're devastating to communities of color, and they're devastating to our society as a whole. As health professionals, our clinical tools are pitifully weak in the struggle to truly care for our patients in this broader context. Our work for our patients is diminished if we don't recognize the social injustices that are at play in the system. We can't be afraid to have an open dialogue about racism in health. Physicians and nurses were inherent leaders in healthcare, and when we shy away from these discussions, it just disguises the impact, or when we try to disguise the impact of racism on health and on our patients, it's just perpetuating these disparities. So we have a long way to go in solving these issues, but I think that recognizing it, talking about it, acknowledging the impacts are steps that we can all take to move forward. I know that this is not what we were trained to do as medical professionals, but to be perfectly honest, we weren't trained to do a lot of the work that we've been doing for the last 6 months either, and yet somehow we've been finding our way. Racism remains a critical barrier to the optimal health of our patients and our communities, and until we find a way to address this, it'll continue to limit it all. So I will end with that, and I wanted to open it up for any questions or comments or discussion that people wanted to have on these issues.
So I'd like to thank Dr. Forman for a really wonderful talk, sort of elaborating on both a number of problems that we're currently dealing with, as well as solutions. Now, a number of people have kind of suggested things in the chat box, but I'd appreciate it if you would type them into the Q&A box so that we can read them and have Dr. Forman answer your questions. I will say that a number of people have written very laudatory comments during your talk and suggested that this would be a talk that would benefit the whole state of Rhode Island, and that you should consider talking to the Rhode Island Medical Association.
Thank you.
Just got our first question. Could you comment, Ms. William Corwin just writes, could you comment on the correction factors for EGFR and PFTs for African Americans that are not supported by fact?
Absolutely. So that's a great question. So we are slowly moving away from this, but far too slowly. So for a long time, there were discrepancies. There were different normal value ranges essentially for PFTs and for GFR based on race. So based on whether you were African American or white, different values were listed as normal, and there was no actual medical basis for this. There was sort of a false basis for it. And there obviously are so many concerns and difficulties with this. One, there was no real research to back this up, and yet we made big decisions about people's health and status and medication and treatment based on it. And two, there really isn't a lot of genetic variation from one race to another, and many people are multiracial or at least biracial. And so asking someone to choose one box and then basing a medical treatment on that is complete falsehood. Race really is a social construct. It's not a biological construct. And when I say a social construct, I mean, this is something that we have come up with as a way to say that we are different from one another, but there's very little biological basis to that at all. That's a good question. Thank you.
This is an amazing lecture. Another question just came in. Thank you for advocating for change in our healthcare system. We're all in need to do our part in addressing structural racism in this country. I'm an NP and have heard some say to start documenting ethnicity in the PHI. What are your thoughts about that?
It's a really good question. To start documenting it or to not document it? Sorry, could you repeat that?
To documenting.
Yeah, I mean, I think in my mind, it's up to the patients themselves in terms of what they want documented or not about their identity, much in the way that we ask patients about what their gender identity is. I think it's up to them to document what it is. Where I find the difficulty is when we constrain people to the check one box. I think that becomes very difficult. And I think for a lot of patients, they are concerned to list a race or ethnicity because of the implications of that in terms of future discrimination. So, I think given the prevalence of racism in our society, it's probably something that should be asked of each individual patient. There's some great, I can share later, there's some really good tools around social equity in medicine and how we can start talking with patients about it. But some of the questions I ask are, we acknowledge that there is a lot of racism and discrimination in medicine. Are there any experiences around this that you want to share with me or you think would be helpful for me to know about in caring for you today? So I think asking those kind of open-ended questions instead of trying to get people to define themselves or give a very restricted definition is helpful.
Then someone else commented that the statistics are eye-opening, and however do we solve this? As a nurse, I've often have patients of color who have their own bias. So how do I approach changing the thoughts and feelings of the patient so I can provide the care I know I can give?
Yeah, it's a hard one. I mean, I think there's there's no one single solution. I do think that talking about this is the first step. I do think that acknowledging this, that this exists in medicine, that this exists in all of us, for me to look at the statistics, I get really overwhelmed, because it's bigger than any one of us. But I can look at my own individual practice and think, where do I fall on this? What am I doing to actively work against this? And where am I maybe falling into racist practices, or where am I falling into subconscious bias? So I think that's one part of it, is to sort of talk about it amongst ourselves and talk about it in the community, and be really vigilant in terms of our own behavior and our own choices where bias might be coming up. In terms of dealing with patients who have prejudice and have different belief systems, I find that open conversation and just being open and honest with people is phenomenally effective. And it's often really scary to do, right? It's scary to talk about race. I was worried about how to talk about it in the context of this presentation. I'm not an expert, I'm one person. I don't know everything that there is to know about this, and it's hard to figure out how to talk about something that's so incredibly painful and divisive in our country, particularly now, but I think all the more reason to talk about it. So I think just being really open and honest with people and saying, I want to know where you're coming from. I want to hear what your thoughts are around this, and I will try to address them as best I can. I don't know if that answered your question or not.
Well, there are no new questions unless someone wants to add one. Oh, wait, just something just popped into the Q&A box. So let's see here. Well, people are commenting on how wonderful your talk is, and clearly there's interest in having you speak beyond Kent Hospital. Does anyone have any specific questions about this talk? Both the first part in terms of the information about the bias and disparities, as well as what can be done about it. And then someone else just wrote, is this presentation available to people for watching after today? And there's 1.5 answers to that. The first is that we recorded this session, and it will be available under Care New England Grand Rounds on HealthStream probably in a couple of weeks, and that will also be available for continuing medical education credits. In addition, we've asked Dr. Forman to write a blog for the Care New England website on this topic. Obviously, it'll be shorter, but hopefully it will begin, or it will add to what I think the leadership of Care New England has been trying to do in the last couple of months to raise the visibility of the area of the issue of racism in healthcare and what we can do about it. And we are planning a talk not on racism in healthcare, but on an issue related to something that Dr. Forman mentioned, but on helping people understand gender identity and what we should be doing, how we can be doing more about that in healthcare. So that'll be an interesting topic that will be later this fall. Now, I don't think there's any more questions. Again, oh wait, there is one. My other question is, how do you get the conversation going with your colleagues, and what's the best way to handle witnessed biased, there's a word cut off there, but I assume it's witness biased situations as a mentor and teacher?
That's both really, really good questions, because these are both things that we struggle with on a daily basis. We certainly in the Kent Emergency Department around the riots and some of the protests that were happening earlier this summer started having some conversations, and they're difficult, awkward conversations to have with people. So I guess the answer to the first part of the question, how do you get these conversations going? I think you can open them up by saying, hey, I just saw something in the news, or I thought about this, or when you see a patient come in with something, you can reflect on it, remark to colleagues about it, and just sort of bring it up, and say, have been wondering about this or thinking about this, or what's your experience with this. I think it's critical that we talk about this with all of our colleagues. I think we all need to start addressing this. I know we're having a moment of silence across the system for reflection in the mornings, but I notice that a lot of people, and I myself have done it sometimes in the emergency department, talk right through it. I think there are always chances for us to say, hey, what are your thoughts on this? And open up the conversations there. And then I think in terms of witnessing biased events, that's really hard and really uncomfortable and takes a lot of courage to do. There are a lot of, there are bystander intervention trainings that focus on this, but there are whole classes on it. But I think to sort of talk about it briefly, when I witness one of those events, I always kind of have to take a breath and call on my courage and just say to the person, hey, can we step outside for a second? I just wanted to run this by you. I don't know how you intended this, but this is how I interpreted what it was that you just said. And I wanted to let you know, because I want to know if I said something like that. And certainly I have had stuff that I have said where afterwards I've gone back to a colleague and said, you know what, I realized this might have come across in a different way than I meant it. Let me explain what I meant. And I own my part in saying something that I shouldn't have said out loud. So I think, creating a culture where we feel comfortable telling each other how things are coming across, and not necessarily in a confrontational way, not in a you're being a racist way, but just saying like, be helping in the context of helping one another be aware of how we might be perceived. I think it's incredibly important, particularly when you're talking about white people showing bias. When you have a system of inequity that benefits you, when you are in privilege, in the position of privilege, you don't have to think about the fact that the system is inequitable. That's the very definition of the privilege itself. So I think it's really important for us to be able to tell one another, hey, you just did something that isn't okay, or you said something that isn't okay. But I think this would be a great future talk is bystander training and intervention.
Laura, what do you think about having sort of groups regularly talk about, let's say, care of an individual patient, and have colleagues discuss how they might have handled situations differently, because that sort of takes it out of the individual realm and more into the becoming a group process, which is something that I've been involved in other situations in the past. And I wondered if you think doing something like that might help here.
I think that could be really helpful. Numbers and sort of big statistical stuff and broad generalizations are good, but we learn a lot better on a case-by-case basis. So I think that could be really helpful for us to do.
So unless there's any further questions, we're just before the end of the hour, and I really want to give heartfelt thanks to you for giving such a wonderful talk, and hope that we hear more from you in the future. And it sounds like people want to hear from you all over. So thank you. Thanks again for doing this and introducing yourself to a large audience. And we really appreciate your taking the time to put together such a wonderful talk. Thank you.
Thank you. And thanks to everybody for being here. I'm really glad that we're talking about this more and thinking about this more. I'm always open to more discussion about it. Like I said, I'm not an expert. I'm just an ER doctor, but I think it's important that we all, no matter our experience and our background, start talking about this together. I think that's how we move forward. So thank you so much.